in between the ligand with the receptor, till it will give you the heart rate. What will be in the middle? What is it? Signaling transduction, all signaling transmissions. I add agonists and antagonists because I was worried, maybe it's not covered from others. Oh, this is a continuation of a drug action. I will tell you why I have done it like this, so that it will be, I have the receptors, everything which is related to the receptors, and then drug of action. Okay, cannot move. Okay, this is, I draw it for you. The targets of drug action, as we said, receptors, enzymes, as we mentioned, ion channel, which is a direct effect of the ion channel, is carrier transporter. Is it clear? Don't mix it with the types of receptors. Now we have receptors, and then in the receptors we have ligand-gated ion channel, we have G protein coupled receptors, enzyme-linked receptor, intracellular receptors. Now in the G protein, there are more details that you need to hear it. By the way, the G protein also you will hear enzymes and ion. Has nothing to do with this enzyme or this ion or this ion. Just in the signal transduction, you will hear more about the signal adenylyl cyclase, phospholipase, which are the second measures. They play the important role in the G protein. Is it clear for this? So you will see this one every time I'm covering, so that you will not, so I'll be covering the receptors, type of receptors, anything is related to receptor, agonists, antagonists, and I go back enzyme, ion channel, because are much easier, this one. Is that clear? How? Oh, let me tell you, in my lectures, the way I put when, usually myself, when I want to study, I don't know if this will help you, I go with the general and then narrow it. Some people know they sit on each and every single word. And myself, I go general, like I've done this one, and then to narrow it. So it's a different way of how you convey the information, or even how you study. Now, remember the ADME, that we have absorption, distribution. In the middle is what? The pharmacodynamic, and then it should be metabolized and excreted. So what's pharmacodynamic? Is the effect of drug on what? On the body, which is drug action. So you have a drug and a biological effect to give you a drug effect. Now, from the drug action to the drug effects is the mechanism of action. And from the time it acts on the receptors till it gives you the effects, which I will always keep heart rate, increase heart rate, so that remember, is the mechanism of action. You will say the mechanism of action of this drug that acts on beta receptors of the heart, which causes an increase in the heart rate. Okay, now what's the signaling transduction, which is the intracellular effects? We will talk about it. So receptors are sensing, usually the receptors, and I tell them like it shows, that if you have something, it's sensing or binding ligands and transmitting message to give you the effects. And from the time the drugs act on the receptors, if it's an agonist, if it's an antagonist, what will do? It just block it. Block it. Does it induce any, activate any intracellular? No. I will explain it more. And how can we block and we decrease heart rate? Okay, so we're talking about agonists. We are activating certain receptors, which is the beta receptors. This one, it will elicit whatever, it's a G protein, or it's a ligand-gated ion, or if it's enzyme linked, or if it's a nuclear one. So they should go to the inside. These are the type of receptors. Then it will start to have signaling transduction in the middle, which is a long process. Not long process, different process, and different protein kinases, involvement of protein, phosphorylation, to give you what? The increase, what? The biological effect. Usually the drug receptor interaction should be reversible. This is what usually, remember when we said your drug, it should act on a target tissue before it gets metabolized. If it activate, it can lead to what? Toxic effect. Also for the antagonism, if you keep it blocking, it might lead to toxicity. Now, the pharmacodynamic, this is the last time I gave it to you in between the ADME. It's a study, as we said, biochemical and physiological effect of drug and their mechanism of action at the organ. As we said, at the organ, when it acts, which receptors? Does it affect alpha, beta, muscarinic, nicotinic? And what's the cellular level? What are the signaling transduction? What's happening? To give you the end effect, it could be stimulation, it will be increasing or decreasing or depressing or inhibiting or cytotoxic, whatever the biological effect. So as you see, this is your drug and this is your receptor. This is one type of the receptor, which is 1, 2, 3, 4, 5, 6, 7. And you have different type of receptors. I will mention it for you. So it should act. Here it should be the signaling transduction in between till they give you the what? The increasing heart rate or biologic response. Is it that clear? Now, okay. Usually enhancement or inhibition of receptor activity. You can activate a receptor who can lead to stimulation, or you can activate a receptor and lead to inhibition. And it doesn't mean every time you activate receptors and give you what? Stimulation. So that, always you do a mistake. It doesn't mean every time we activate a receptor or stimulate the receptors, the end effect is what? Increased. No, it could be depressing or inhibition of whatever. It depends on the physiological function of the target. Is that clear? Depending on the physiological function. So usually when we say if the response is stimulant, we call them CNS stimulant, or if it's inhibition or depression, we call them, how we categorize the families of the medication, we call them CNS depressant. If they depress, we call them CNS depressant. If they stimulate, we call them CNS stimulant. Now, pharmacodynamic, remember we have receptors and we have, I wrote 3 receptors, it means yes, receptors, and other, which is non-receptors. I will just, the receptor usually where they are found. Usually, most of them on the surface, but you have one which is not on the surface, but usually they are on the surface, and we might find intracellular receptor. When you call them intracellular, should be what? Nuclear. They should. So what do you expect your drug should be to diffuse throughout all of this? It should be high, what? Lipid, high lipophilic, okay? Okay, so that it crosses, it acts intracellularly, which is, I will give you some lectures, some schematic figures now. So most, and usually, we have histamine, we call them histaminergic receptors. We have nicotine, we call them nicotinic receptor, muscarinic receptors. And the medication, you will hear them, when we say we are taking an antihistamine medication, what will be acting? What do you expect acting on what? Histaminergic receptors. Now, the non-receptor mechanism, let's say antacid. Anyone can drink antacid, liquid antacid, or, if you have acidity, some people, what they will take? Magnesium or milk, هدول اللي بيجوا like liquid, okay? Go read how they will act. If this is you have acidity and you take an antacid, do you think they will act on the receptors or just acidity and alkaline to bind it? So it's non-receptor, has nothing to do with receptor or enzyme or anything, okay? But mostly what you will hear, it's always receptor, but sometimes you might hear about like stomach acidity, we give antacid. Some of these medications, they contain alkaline ion that chemically neutralize stomach gastric acid. But still the most common is what? The receptors. Now, my God, I will be covering drug targets for drug action outline, which is, this is going to be repeated every time, or I'll be circling what I'll be covering. Receptors, that's why I put it for you in yellow, which is most common. Enzymes, ion channel, which is a direct effect on the ion channels, and carrier transport. Now, when you say targets for drug action, remember targets of drug action, where is the drug is gonna go act, okay? Usually on a macromolecule, either protein or DNA. Your target, we said, we agree it's a receptors or enzymes, some of you said, or ion channels, or what? Carrier and transporter. Now, I just put for you little examples because I need it for the MCQs, which is, it will be repeated and repeated at the same time. Now, receptors, now, I know by now, epinephrine, what will do with the heart? And so how can we block it? Propranolol, which is the receptors. So you see, now we are talking in general. When we go more into cardiovascular block, you will not tell, you will be, do you know that beta, it has how many subtypes? Beta 1, beta 2, beta 3, beta 4. Do you know which one is darkly on the heart, which is found mainly in the heart? 1. Okay, remember 2, bronchodilation. Remember beta 1, the heart. So which is better to give if you want to increase the heart rate, to give epinephrine, or we give a beta-1 agonist, specific agonist. Usually we want to increase the heart usually when anaphylactic shock, so we give epinephrine, okay? But if you want to block, usually we are into most of the cardiovascular block, you will hear about arrhythmia, fibrillation. So what do you want to do? So do you want to decrease the heart rate with the propranolol, which is a broad that block beta-1, beta-2, beta-3, beta-4, or you want something specific to the heart? So always you will hear subselectivity, selectivity of this medication. That's why we have, the more you are selective on the organ, you have targeted the right effect, plus the side effect is what you minimize it. Great. Usually cimetidine blocks what? The H2 receptor. Cimetidine is what? Is more related to GI. It's different when you're talking about the derma H1 receptor. So we have H1 and H2 receptor, by the way. The H1 has to do with the derma, with skin, urticaria, or eczema, and where the H2 is related to what? To the stomach and ulcer and GI. So we have the cimetidine, and we have ranitidine, and we have the Nexium. I don't know if you use those medications. Do you use any medication for? And usually, and as I told you, before taking any non-steroidal, I mentioned it last time, non-steroidal anti-inflammatory drugs, you need to use those medications to cover the stomach. Now, enzymes. Usually, we have those inhibition of acetylcholinesterase by neostigmine. You will hear it when I will give you the cholinergic, I think, agonist and antagonist, more which is related to neostigmine and cholinergic agonist and antagonist, or inhibition of cyclooxygenase by aspirin. So we are affecting an enzyme to reach the biological effect. Now the ion channel, which is a direct effect on the ions, which is the local anesthetic. Local anesthetic, they block directly the sodium channel. Where's the sodium channel? They block it. There is now another figures that I will add for you. This is directly on what? On the channels. Now carrier, I remember I mentioned this last time, blocking norepinephrine uptake by tricyclic antidepressant. You know, the depressed people, some of them we need to have more norepinephrine. Can you remember synapse where the neurotransmitter stored and then released by exocytosis? You need action potential, and then when it's released, I put it for you at the end, it should act where? On a postsynaptic receptor. Does it make sense for you, all this pathway? So do we need to keep the norepinephrine all the time at the postsynaptic? If you're activating, no. So what will happen? How it can be taken into the cells? Hello, axil exocytosis. No. Transporter or carrier, okay? So there is it like a car will take the norepinephrine to the inside to be stored. Now, if you want to block this carrier, what will happen? More norepinephrine at the postsynaptic, right? This is one of the tricyclic antidepressant medication. This is the way act. They block a transporter. What will happen to the norepinephrine? It will accumulate at the place where they want to act, alpha, beta 1, beta 2, or whatever the action, okay? Is that clear? How you will have now receptors, enzymes, ions, and carrier. This is the receptors, which is the receptors that have subtypes. Remember when I tell you the receptors, what are the subtypes or the family of the receptors, which I will cover it later. This is an agonist. Antagonist, just it blocks, no effects. This is the ion channels. This is the enzymes. Remember when we say prodrugs or metabolism? Okay, some of them we need a prodrug to in order to act as a we need the active metabolite, and this is the transporter. This is just to cover for you the whole, remember receptors, ion channels, enzymes, transporters. This is without an example, just an overview of how they will act if you're blocking the permeability, like in local anesthetic or prodrugs. Sometimes you give them false substrate, and sometimes, I'm sure in the cholinergic or sympathetic, you need a certain enzyme so that at the level of choline. But if you give them a false enzyme, what will happen? Will it have the same? So you are falsing or fooling the choline that it's the same enzyme, but if you're giving it a wrong enzyme, which is structurally related to the enzyme that's used in the cholinergic, so so what will have a false substrate and will not act. This is just a general overview. When it comes cholinergic, you will understand when we will use those. It might be ion or enzyme or transporter. Now, receptors usually receive and respond. When it's an antagonist, does it respond? Okay, but I'm talking about usually now when we have receive an agonist and we have the intracellular effect, so there is a response. So upon recognition, as you see, of appropriate chemical signaling or ligand or a drug or a neurotransmitter, receptor, what will happen? Sometimes you will hear it somewhere in the book, they call it key and lock, okay? Transmit signal, it should, as you see the receptors, we said it's extracellularly, and you have the membrane where sometimes it's spanning around the membrane, and then this is where once it acts on it, it will start the signaling transduction. It could be a drugs like what you will hear in all your blogs, or hormone or neurotransmitter. Now, this is, I already mentioned it, epinephrine acts on which organ? We said the heart. So it binds to which receptor? The beta. And then if you want to talk more specific, beta 1. Beta 2 is related to what? What? Bronchodilation. طب الأزمة they will take sympathomimetic or sympatholytic. You broke the sympathetic activity or you activated. We have beta 1, it increases the heart rate. Beta 2, what does it do? Dilate. So when you want to give something for asthma, what will happen?
You want to dilate.
So you will give agonist or antagonist for beta 2? An agonist. So remember, if somebody have an anaphylactic shock, I want to know, I hope you could answer it. If you have someone anaphylactic shock, okay, they are going to be suffocated. So you'll give them epinephrine. Epinephrine acts on beta 1 and beta 2. What will happen to this patient? So what will happen to his bronchospasm? It will be dilated, but at the same time, what will happen? Heart rate might be increased, and you have to worry about his heart rate. So if you give, so that's why this is if it's an emergency, but usually somebody who's asthmatic and they take beta 2, that act on beta 2 to stimulate the dilation in case of asthmatic. So now that's why propranolol, do you know propranolol what's used? Propranolol is a what? It's a beta blockers. We didn't say beta 1, beta 2 or whatever. So if it blocks beta 1 and beta 2, what will happen to an asthmatic patient if you are decreasing his heart rate? بيصير عنده bronchospasm. So you might decrease blood pressure or decrease the heart rate, but what would happen at the same time? You might cause, so it's avoided usually so that's why you have to understand the concept of these receptors, how they act. That's why if we need to decrease blood pressure, we try to give, or decrease heart rate, to give what? Something does not affect the beta 2, especially if he's an asthmatic patient. Well, I didn't know that you are good in this one, so we'll add for you more examples that's more specific. But this is at least the overall, you understand it. It binds to beta receptors. So when it binds, you have a train of reaction, we call them the signaling transduction, leading to increase in what? Heart rate. Now, in case of tachycardia, we block the beta receptor, bring heart rate back to normal. Is that clear? Okay, agonists and antagonists exist for receptor with this type of physiological role. Yani adrenergic والcholinergic, they have agonists and antagonists. I will be covering after your exam the cholinergic agonists and antagonists, I think. So we'll be talking more about what are the agonistic drugs and what are the antagonist drugs and why we use them for which. But please, before you start adrenergic or after you finish the exam, read the sympathetic and parasympathetic. It will help you a lot. Review the sympathetic, what they will do. Mainly sympathetic, their effect is what? When you say sympathetic, is related to what? Increasing heart rate or blood pressure, like this, okay? What about the parasympathetic? Remember sympathetic, and I usually before I give it, if you see a lion, what will happen? Heart rate, you run. When you are at the cinema movie eating popcorns, and what will be more dominant? The parasympathetic, which is how it will be the eye dilated or constricted, and you'll be more into urination. It will be active more the GI rather than, you know, when you're watching movie, your heart rate is decreased and like this. So usually in now, if you're happy in our lectures, you'll be the parasympathetic dominant. But when you are in the exam, what will be more dominant? Sympathetic. Now, okay, I covered the receptors. Before going, what are the enzymes and ion channel? I need to cover all the story of the receptors, and then we go back to enzymes. So we know we have ligand-gated, G protein, enzyme-linked, intracellular. Is that clear? Does it make sense for you how the flow I've done it? And I can cover receptor, enzyme, ion channels, carrier, and go back to receptors, but I prefer to have the receptors, give all the details of the receptors, and go back what are the other drug action. Now, the type of receptors, we have ligand-gated. When you hear it, ligand-gated, what does it mean?
Transmembrane channels that allow ions.
Ions. So just remember it's ions. And depolarization, hyperpolarization is all more related to ions. When you say G protein,
Second messenger.
yeah, here when you need to remember, because I have يمكن most of my MCQs on G protein, and really it's important the G protein to understand all the G protein and what are the involvement of G protein. Enzyme linked, what does it mean? When you say enzyme linked, does it mean the receptor is linked to what? The enzyme, usually it's tyrosine kinase, or usually the insulin, you will hear about it. Intracellular receptor, ما أعطيتك example. What does it mean intracellular? What does it mean? Your drugs, everything should be where intracellular, which you will hear in nuclear. Now, this is exactly what I was telling you, ligand-gated ion. As you see, your ligand will act certain ion flow, whatever its hyperpolarization, depending on what receptor we are talking. The other one, which is a G protein. Remember the G protein, go back to your little biochemistry, and the G protein, it has a lot of information in this lectures. You have the alpha, beta, gamma. Remember how to act the G protein?
Yes.
Okay, good. Well, they're good, they're great. I cannot remember your class, they were like this, POD. Okay, and if it's enzyme linked, remember it has an enzyme, which is the tyrosine kinase. لأن semester 3, let me tell you, we have sometimes semester 3, either they are all great or they will give us hard time, or they will find difficulties in passing semester 3. And then the last one, when we said intracellular, where it should be your ligand is what? Lipid soluble, so that it will enter into the nucleus. Now, the structures, I will not go ask you in the structure, but you have to know what are the difference. When we say ligand-gated, you see the binding domain, all of them where they are, the ligand domain, extracellularly, except one, which is the nuclear. Really, you have to remember, if you understand it, you will remember it. You don't need to memorize it. So most of them, they are extracellular, except one, which is intracellular. Now, remember the ligand-gated, there's an involvement of channel, usually 4 to 5. But the most important that you will hear about it, which is the G protein. Remember the G protein, it should be attached to what? A complex, what's called anchor to what? The G protein. Before the GTP, alpha, beta, gamma, complex, okay? And membrane, it's what? It's a 7 transmembrane spanning around. This is what you always hear about it. Now, what about the kinase-linked receptors? As you see, it's their binding domain is extracellularly. As you see, it's a one membrane, one transmembrane. And remember the catalytic, because it should be having the enzyme. It cannot triggers or start the biologic until have this tyrosine enzyme, which is this is I circled the most important. Now the nuclear receptors, all of them, they are intracellular. Now, okay, We talk about in general the receptors. I covered the ligand-gated in general. Like you see how I built my lectures in general, and then I go to each and every one. So ligand-gated, G protein, enzyme link, intracellular. It will be easy now to give more details about the ligand-gated. This is the ligand-gated ion channel, regulation of ion flow across the cell membrane. As you see, you have the receptors, you have your ligand or neurotransmitters or drugs, and what will happen? Opening of certain channels to do, it can lead hyperpolarization, depolarization. Opening channel to increase, it might be increasing ion flow through channel or closing. Usually when I put green and red, for me the I go with color coded. Green, it means opening. When it's red, it means closing to decrease ion flow. Usually the response is very rapid. You will hear it, and I will give it more in details when you take the cholinergic agonist. As acetylcholine on nicotinic receptor. Do you know acetylcholine acts on which receptors?
Nicotinic.
And what else? It acts on all nicotinic and muscarinic. Or do you think acetylcholine can be given as a drug? Is it beneficial? Don't say yes, then it's no. Remember, where else you will have nicotinic? In the ganglia, right? In the muscles. Or you have, so the acetylcholine, it acts in many places. This is where usually the venom, just look how the snake venom or the scorpion venom, they will act. They will activate all the parasympathetic. That's why they are so toxic. Nicotinic receptor, usually what will happen? Sodium influx leading to action potential resulting in skeletal muscle contraction. Remember, if you have a venom that will activate all of your skeletal muscle, you are contracting, what will happen? At the end, we'll have paralysis. I'll mention it more in detail in the cholinergic. Is that clear how the ligand-gated will work? So through ion flow. Now the G protein. يا مسهل. This is like the most, it took me a lot of time to just simplify it for you. I put different pictures or different wrap-up or different overview, but they are the same, but in a different way. As we said, is the what? Is a seven transmembrane, am I right? Spanning around the membrane. It's linked to what? Alpha, beta, gamma protein. Remember, did you hear about GS and GI?
Yes.
Stimulatory or inhibitory. The GS is related to what? What are the second messenger? If you still remember GS or GI?
What are ايش؟
The second messengers.
Oh.
Yes. لا شوفوا. Okay. اللي قالت الاي بي 3 والداك keep them together with the intracellular calcium. Okay. What did you say, Habasa? You say something. Cyclic AMP. So either we have an increase or decrease depending on the G protein. So the G protein, as we see, we have the alpha, beta, gamma, and usually, somebody told me before, we have the what? The GTP. When it will be starting to move to GTP and replace the GTP, when you have the ligand act on the receptors, and you have the alpha, beta, gamma, what will happen to the alpha? Dissociate and will take what? The GTP or GTP? T energy. Okay. Other enzymes, ion channels are involved. Remember that we have ion channels involved and enzymes also involved. Second messenger are responsible for the cellular effect response second to minute, like norepinephrine, IP3, and DAG regulates calcium. Why I put for you this one? Okay, because anyway, depending if it's stimulatory or inhibitory or what, GQ. And GO you have. How many types of G receptors?
4.
Yeah, GO till now, I don't know. Till yesterday, I read if they find something about it. GS, GI, GQ. So this is a function of G protein. As we said in the resting membrane, we have the receptors. You have the alpha, beta, gamma with what? The GDP. What will happen when it's coupled to a ligand? Usually it will dissociate and your GTP will be replaced by what? A GTP. And then the alpha GTP and beta gamma, what will happen? They go target certain enzymes, ion channels, till they give the intracellular effects, and they then dissociate, and the GTP will dissociate and will be back to its resting membrane to have the GTP back again. This is again, it's another explanation for the first one. Now, remember the pathway is controlled by receptor via G protein. You have the enzyme phospholipase C or adenylyl cyclase or ion channels. Also, so remember we have the enzymes and ion channels where under the G protein has nothing to do from the enzyme at the beginning, has nothing to do with the type of receptors. Remember this. Both can be activated or inhibited by pharmacological ligands. I put for you YouTube just to look at it for you at home because I don't want to take from time of the lecture. Now remember, again, it's another picture I put for you, which is a G protein. It's either stimulatory or what? Inhibitory. Also, I told you that ions will be involved and enzyme will be involved, and then your second messengers will act to give you the what? The biological effect. Now, an example of ions, if you have a G protein, if you have an agonist that stimulates certain receptors, like we have the muscarinic receptors, what will happen? Increased potassium permeability. You're increasing the, so now, remember when I say muscarinic or the parasympathomimetic, what will happen usually? Your heart rate is what? Decreased, okay? Usually now we don't give parasympathomimetic or something, an agonistic on the parasympathetic decrease heart rate. We give a what? A blocker on the sympathomimetic. These are the most medication. But if you give a muscarinic receptor, what will happen to potassium permeability? Increase. What will happen to electrical activity? So you're activating the muscarinic, but the end response is what? So remember at the beginning when I tell you can activate receptors, but the action, you never know if it's increasing heart rate or decreasing. So this is a good example to tell you, you activate the receptors, but the biological effect could be like in here, decreasing heart rate. And it's acting through what? The ion channels. It's a G protein, but activating as well the potassium. Now, another G protein, which is more into enzymes, I just give you those. Ahmed, who's Ahmed? هيك شايفة صورة أحمد. Who's Ahmed? Ahmed, I have his picture. Ahmed, are you here with us? Well, just his picture. It looks his picture, right? Ahmed, what's his name? Ahmed what? What's his full name? Ahmed, can you answer me? Or wake up? Or send him a WhatsApp group, Ahmed, to answer me? But or else I'll put him. This will tell you what the one they are staying at home, they're not opening their computer. Maybe some of them. Anyway, the other one, which is more acting into enzyme, the cyclic AMP, you will hear them, the salbutamol. We talk about salbutamol, which is a bronchodilation, and the antagonist propranolol. And I for you, histamine and ranitidine. Ranitidine is like cimetidine. I'm trying to keep the same example from the beginning so that you will not be lost. So it's salbutamol, which is what? Is what salbutamol? Bronchodilator. So it's what? A beta 2. This will tell you a beta 2 effects, and propranolol. As you see, propranolol can block here and this one. So when you want to give someone a more selective to block the heart rate, say hi to Ahmed and I will mark him absent. What does it mean atenolol for you? And I will not give you the sympathetic, I think Dr. Manal. But why we have atenolol and we did not use propranolol?
Because propranolol is more
Beta 2 and beta 2, beta 1 and beta 2. What about the atenolol?
it's more specific.
Okay, great. And why we use salbutamol? It's more specific on what? Bronchodilators. Okay, histamine, we will never give histamine to anyone, for sure. But we have antihistaminergic. I put for you because I mentioned about the acidity and because it's more into GI, and we have mepyramine, and we have for runny nose or urticaria, so are the H1. Now, the second messenger are triggered by first messenger. So they are triggered, how they will be triggered? What's your first messenger? What?
Ligand.
Yes, or chemicals or neurotransmitter or like that. that binds to the receptors. So it's the intracellular signaling molecules released by cell to trigger physiological changes such as proliferation, differentiation, migration, and apoptosis. They include cyclic AMP, cyclic GMP, inositol triphosphate, diacylglycerol, and calcium. Remember, IP3, diacyl, and calcium, they go together. And then you have cyclic AMP and cyclic GMP. Cyclic AMP is what related to what? Which enzyme? Adenylyl cyclase. So if it's a stimulatory, you expect to be what? Increasing cyclic AMP or decreasing? Increasing. If it's GI, okay, so G stimulatory, it stimulates which enzymes? Adenylyl cyclase, leading to what? Increasing cyclic AMP. This is your second messenger's story. GI inhibits adenylyl cyclase, cyclic AMP. GO till now is controversial, so many review, but nothing I can say it for you. What about GQ? Is activating phospholipase, increasing the IP3 and diacylglycerol. Remember it by heart, this one. GS, GI, GQ. Now, adenylyl cyclase story, GS or GI, we have the adenylyl cyclase catalyzed formation of what? The intracellular messenger, what? This is your cyclic AMP. Cyclic AMP related to protein kinase, what? A. That controls cell function in many ways by causing phosphorylation of various enzyme carriers and other proteins. Is this clear about the adenylyl cyclase second messenger of the pathway? As you see here, but let me tell you something. While in this pathway, always remember that we have an agonist, we have the G stimulatory, let's say, and we have increasing cyclic AMP. The protein kinases, usually they are inactive, and they what? They render them into active. But remember, those protein kinases, sometimes they will activate your others enzymes in the pathway or deactivate. So depending, are we talking reducing glycogen synthesis, what will happen? You have to deactivate them or inhibit them. Where if you are talking about increased glycogen breakdown, so not all the time in all the pathway to be activating, it might be an enzyme which is in case of glycogen synthase, it's an active, it will render it inactive, your protein kinase, or it will activate it. But it will be in each lecture that you will take later. Blocks, if we're talking about insulin and like this, you will know more about it, and we will give you all the second messengers, how they will act, or each drugs, how they will act. Now, what about the phospholipase C, IP3, and diacylglycerol catalyzes formation of two intracellular second messenger. Remember the IP3 and diacylglycerol from the membrane, which is phosphatidyl inositol, we call it PI. IP3 usually is related directly to what? When you say IP3 is what? Calcium. Calcium what? Intracellular. Free cytosolic calcium by releasing calcium from intracellular compartment, increasing free calcium, and always when you have IP3, intracellular calcium is related to what? Contraction. And this is the usual. Many events, including contraction, secretion, enzyme activation, and there is membrane hyperpolarization. What about the DAG? It's more, it will activate protein kinase C, controls many cellular function by phosphorylating a variety of protein. The G protein also, they control phospholipase A2. I will give you a picture. Now you have phospholipase what? How many phospholipase we cover? Okay, so you have the phospholipase 2, which is more related into arachidonic acid and eicosanols. I think one of your lectures, otacoids, you have upcoming lectures, the POD, otacoids. I have your timetable. Okay, and also we have ion channel, potassium and calcium channel that's affecting membrane excitability, transmitter release, and contractility. This is a G protein summary. Remember, we have an agonist activating membrane bound receptor, agree? And then your G protein is activated and produces either the adenylyl cyclase or phospholipase C or phospholipase A or guanylyl cyclase, agree? So now if you are activating the adenylyl cyclase, what will be your second messenger? So if it's a G stimulatory, increase and increase. If it's G inhibitory, decrease, decrease. If a phospholipase C, now I mentioned it will be IP3 and diacylglycerol. The A is related to what? I just mentioned it. the eicosanoids and the arachidonic acid. Now, if we're talking about guanylyl cyclase, it means cyclic GMP. So again, another, trying to summarize for you all the G protein. This is, you have to remember it. Yani this is really the whole pathways, or really, if you understand all, you have to memorize. When it comes to this one, remember. Your target enzyme, let's start with adenylyl cyclase. If you target if your G protein and you target enzyme adenylyl cyclase, what will happen to second messenger? Cyclic MP will be released, and what will be your protein kinase involved? PK. And if it's phospholipase C, IP3 diacylglycerol, and I put for you the intracellular calcium. Remember, we have this one where the arachidonic acid and eicosanoids. Anyway, I have a table. I didn't put for you any example on it. This is related to phospholipase what? And now, if it's guanylyl cyclase, what will happen? Your second messenger is what? GMP. And what's your protein kinase? So you have different protein kinases. You have to relate PKJ to cyclic GMP, guanylyl cyclase, PKA, cyclic MP, adenylyl cyclase. It's easy for you to remember A, okay? This is another way if I want to memorize something. G. So the C phospholipase is IP3 and diacylglycerol and protein kinase C. And now, as you see here, it's a train of things that will happen to lead whatever the effect you're looking for, the biological effect. Is it clear, the G protein? Now, I put for you this one, an example from epinephrine and an example from the oxytocin. And I was putting arachidonic with cyclic GMP, I removed them, but I want you to remember. So epinephrine, we said it acts on alpha 2, beta 1, beta 2. Epinephrine acts on all adrenergic receptors. So if it's acting on beta 1, which I always repeat it, what will be your adenylyl cyclase, cyclic MP, protein kinase, and what will be the effect if activating beta 1? Increasing heart rate. So I'm relating it to one of the neurotransmitter, epinephrine, beta 1, adenylyl cyclase, cyclic MP, protein kinase A. Now, if it's oxytocin, which is a hormonal, or it's related to GQ, phospholipase C, IP3 DAG, and protein kinase C. So this is later in each block, you will know each medication, how they will act for. Is that clear? This is the only two examples. It might be, well, I cannot remember the MCQs, but I remember I wrote something regarding this one, but in a clinical scenario. So it could be, somebody, he have a problem and he went to the ER and he want to take one of the medication that will do something through which, so I might ask you through which second messenger or protein kinases. This is the way I'll ask you, but it's related to this one, but it's not a direct, if really read, don't worry about my clinical scenario, maybe lots of words, but one or two words, you should pick them up, which is related to your questions. Now, the enzyme linked, it's much easier. Is it clear that G protein? Please, if you have any question before your exam, now.
I have a question.
Yes.
The G protein, which type of G protein activates cyclic GMP?
Which what?
Which type of G protein activates cyclic GMP? Like G protein A activate cyclic GMP, and G protein Q activate phospholipase C. This pattern.
There is no G protein A أول شيء عشان أتأكد منك if I understand the question. So G protein, if it's stimulatory, it will go where?
It's stimulatory will go to the cyclic GMP.
Okay. If it's inhibitory? If it's inhibitory, please, and I will not stop the question, but if you have still question, review my, if it's inhibitory, can somebody answer him so that I'll make sure that you understand it? It's the same adenylyl cyclase and cyclic MP, what will be what inhibited. The GO, what did I say? Unknown till now. Okay. What about the GQ? It's more phospholipase C, IP3. You need, please, whatever your question, if it's not clear to me, if you still read my lectures and you browse your and you need still to ask me any question. But I'm sure يعني والله it took me over the week and with the accreditation to make. على فكرة, do not take my old one because each one it was one lecture. This one I combined 2 lectures in one lecture, and I try to do this. But still, if you have any question, you can still send me an email. Or Barakat is your the other day. Mean Barakat. Farah, I sent her question of the year 3rd year. She told me I'm POD. So if you have any question, I will share it with her so that she will share it with you. Now, is it clear about the ligand, the receptors of the ligand-gated involvement of what ion? G protein. Remember, we have different type of second messenger, protein kinases. Remember, this is like a train map, where to go, where to come. But if you have to know if it's your G protein, depending it's stimulatory, inhibitory, you will know what are the involvement of the others. Now the enzyme, remember adenylyl, cyclase, phospholipase, these are the second messenger that you will hear more about them. Is it clear? Remember that you have, it will affect certain ion channel. I just put it here. It has nothing to do with your ion channel, which is when I talk about the local anesthesia. Now the enzyme linked receptors is very easy and simple. It's a membrane receptor. We said it's what linked to what tyrosine kinase in nature, such as insulin and cytokines. They should act on certain receptors. Okay, it's a cytosolic enzyme. So the membrane, the ligand is what, and or the cells where it acts, the receptor should be extracellular or intracellular. Extra, but the enzyme is cytosolic. What will happen? Phosphorylation of multiple amino acid, as you see, protein phosphorylation. This phosphorylation will activate other protein kinases, receptors in minute to hours, like insulin having tyrosine kinase as a part of structures. Now, if I want to cover the intracellular, it's much more easier. Somebody said an example about it. Who said the example? The one with white top, I think you told me. He خبي التليفون. He just hide the telephone. What was the example of intracellular receptor? I think you are the one who said it. Steroids. So what will happen? What does it mean? So you can know the whole story. The receptors, where are they located? Cytosol, they migrate to nuclear compartment, regulate gene transcription as steroids hormone. As you see, all of it is what? Nuclear. This is the only one which differs from the others. As you see, the receptor and the ligand should diffuse all of them inside the receptors. And it should be what? Lipid soluble. Response is in our, like we have the estrogen, like the steroid hormone. Is that clear? All types of receptors? This is all type of receptor. You have the ligand, the kinase, and the nuclear. The only one is this one, the G protein, which has more details. Now, I will continue with the receptors, but still we have the drug target the receptors. I was covering all the time now what are the receptors. Still you have the enzymes. It's easy. And what? Transporters and ion. Now, just I need to make sure that you understand the agonists. Did you take agonists antagonists during pharmacology this year? And I check all the lectures on the model. I don't know if anyone covered for you agonists and antagonists. What? You did? ما مين؟ يمكن مع دكتور دليب. Yeah, he did not upload but his على المودل صح؟ I didn't see it on the model. So. Okay, so it binds. Okay, I want you. Okay, let me go. Usually, this is a really question if you really understand agonists antagonists. Now we have the sympathetic and we have some parasympathetic. If you block the sympathetic by a beta blocker, okay, and this is it's a blocker, okay? Does the blocker act or introduce any, elicit any response? So how it will decrease the heart rate? Well, exactly. Yes, prevent the action of agonists by preventing the action of neurotransmitters, the epinephrine, norepinephrine that we have it. This is what I need to know. When you're blocking certain receptors, how it will decrease the heart rate. And this is the most important part for me to understand how as an antagonist, it prevents the action of agonists or endogenous molecule or receptors with the acid blocker. Is it clear between the Type agonist epinephrine, I think you know it, and propranolol, I already mentioned it, and you said. But now, did you take, what does it mean, reversible or irreversible? I think you know it. Reversible, it means, and like the agonist, you want also the antagonist to be reversible. If not reversible, and I will cover it like the nerve gas. During war, how they will act. They will not be reversible. They will be activating until the respiratory depression. I will cover it in my no dissociation or very slowly, no change. But usually when you have, they are competing both, I think it's in the second slide, yes. If you have, I will not. If you have a competitive agonist and antagonist, what will happen? If you have مثلا toxicity with an agonist, what will happen? What we will do to overcome the effect of toxicity of an increase of agonist. مثلا عندنا acetylcholine, a lot of acetylcholine. What should we add to compete with it and remove it from its place? What should انتوا عندكم محاضرة أصلا, you will open it. They compete, when we say competitive, they compete for this receptor as acetylcholine. How to overcome? Let's say مثلا someone he has taken a lot of acetylcholine. If atropine compete for the same receptors, and it's like we have a lot of students, they can sit and all of them they compete. If you have more students, that they can remove him from his place. So that's how you compete. You increase a dose of an antagonist so that you remove the what? Because they are competing on the same receptors. Now, if they are non-competitive, this is usually antagonists do not bind, they are not binding on the same receptors, but act to prevent the response to an agonist as calcium channel blockers. Usually calcium channel blockers, we give them to decrease or to, I will not tell you, calcium channel, you will have them in the cardiovascular block, okay? They prevent, when you have a calcium channel blockers, what will happen? They are blocking the what? The calcium influx. So that's block contraction of smooth muscle produced. They are not acting on the same place, but they are preventing the calcium influx. Now, chemical, it's easy now. Remember when we say acid or antacid, how this is our, by the way, agonist or antagonist. We have an antacid, or sometimes we have, some people, they will have toxicity with heavy metals. So we give them chelating agents so that they'll bond on it. And so this is just, it's a chemical bond. Physiological or functional, this is, I already mentioned it, or I repeat it again. Like somebody, let's say to have anaphylactic shock. Anaphylactic shock, what does it mean? Let's say he have a mosquito bite or a bee's bite, and he have a lot of histamine release, okay? So should we give him antihistamine? And why we give him adrenaline? When I say anaphylactic shock or bees, it means a lot of histamine, okay? His anaphylactic shock, yani, he will pass away if we did not save his life. Should we give antihistamine? The antihistamine usually is oral, or we give epinephrine. What will happen, epinephrine?
It will increase the heart rate.
And what else mostly in the histamine? Bronchodilation. Remember, so both of them, they're acting on different systems. We are talking histamine, it acts on histaminergic receptors, causing what? Bronchoconstriction, bronchospasm. So if you want to, this patient to save his life easily, you give him adrenaline. What will happen? The adrenaline or epinephrine? So directly bronchodilation, yes, he will have increasing heart rate, but they will monitor it during, but we will not give him something antihistamine. We might give him steroids and others. But this is, you are bronchospasm and bronchodilation on different system. One in histaminergic that affecting the bronchi, where the other one is bronchodilation through what? The adrenergic system. So this is, we tell you how we can antagonize the effect on different systems, not on the same receptors, two different systems. Is it clear? Still, if it's something that you missed it, honestly, I will add me. I think I already mentioned it. Remember when we said try to avoid to take calcium with tetracycline because it will affect retard absorption or metabolism. Remember, if you have something inducer or if you take warfarin, remember warfarin is a very important drug that you will take it. If you have an inducer, what will happen to warfarin? It will be what? If it's inducing it, you're lowering the therapeutic effect. If you are inhibiting the metabolism, what will happen? You're putting the patient into what? Bleeding. I mentioned it already, bill metabolism. Now, the last thing that I will cover, they are easy. Enzyme, ion channel carrier transporter. Enzyme influence reaction, increase or decrease enzyme mediated reaction. Usually stimulation, somebody should be attending and now she want to take the 12 to 1. Do we have lectures? Usually no. Stimulation usually by endogenous chemicals like epinephrine stimulates hepatic glycogen phosphorylase, hyperglycemia. This is an internal. As for drugs effect exam, usually what we give the drugs usually to inhibit enzyme and not to activate. Now the ion channels are proteins that take part in transmembrane signaling and regulates ionic composition of the cells. Drugs that are directly action on the channels, as we mentioned. I gave you an example, which is the local anesthetic, or remember we have ligand-gated, or we have the G protein. So we have different places where the ion channels. This one is directly on the ion channels. I put for you the local anesthetics on sodium channels, how it blocks. You see, that blocks the effects, and no blocking the sodium channels, no action potential, the signaling inhibition will be decreased. You can look at this one, how to act. It's directly on the ion channel. Now the target, we have ion molecules transported across membrane by binding to specific protein due to their insufficient lipid solubility. Many carriers responsible. As I told you, and I gave you an example of noradrenergic and tricyclic antidepressant at the beginning, but also always we have a reuptake of neurotransmitter precursors. The acetylcholine, it will be, how it will be transported into the synapse. Do you remember?
Yes, increase
choline.
channels. Transport proteins. We increase the number.
But acetylcholine, does it enter as acetylcholine or it enters as choline and another substrate?
Choline and another substance.
So that you will have the acetylcholine, you have certain enzyme storage. You will take it with the, when I will cover, like norepinephrine, I said there is a carrier to take it inside the cell. Also, there is the cholinergic acetylcholine, how to be entered into the sinus. I put for you a picture at the end just to give you an idea. I'm sure in the biochemistry they touch it for you. Usually, if you have a drug that interact with with the carriers, like hemicolinium, they decrease the acetylcholine transmission. So if you don't allow any choline entering, so you will not have acetylcholine to be synthesized or to be stored or to be again released. Also, I talk about tricyclic antidepressant that if you block the carrier, that will take. I will show you this one. This is really important. Keep it with you. This is where we'll tell you. This is about norepinephrine. If you see, you can really, drugs the way they can act. They can act on any enzymes. If there is any enzyme, you see, if you decrease any enzyme, you might, if you decrease the enzyme, you will not have dopamine. It will not be stored in this one. If you have something to affect the calcium channels, it will not be exocytosed. Am I right? This is, you have enzymes, you have the channels, here's the carrier, okay? If you block, usually norepinephrine, if it acts on postsynaptic, remember that we might block these receptors, the norepinephrine receptors or adrenergic receptors, which is alpha, beta 1, beta 2. So what will happen to norepinephrine? It should be taken again to where? With the carrier inside. So if you block this carrier, what will happen? So you have more norepinephrine, which is more the tricyclic antidepressant. When it's negative here, by the way, this is, you have to remember, tricyclic antidepressant. Remember when I tell you tricycline, you prevent the carrier of taking what? The norepinephrine. What will happen to norepinephrine? More acting. And this is the way you treat the patient if they have depression, to have more norepinephrine. Taban, with certain dose, you don't want them. Is it clear now? Please, if you have any question before the exam, you can send me over email, and best of luck. Well, I hope, it really took me time to prepare this, to make it simple and easy and direct. Ahmed, still Ahmed is not here?
No, yes.
Tell him, Ahmed, you are absent.
Doctor, there are some questions online.
If they want, it's 12 o'clock. I need to go, but whatever.
Doctor, we can turn on chat.
Oh my goodness, 144 chat.
No.
Yeah. My goodness.
Doctor, some of them wanted you to explain the histamine slide again. They're just answering your questions. Yeah.
Is there an enzyme in C?
Yeah, it's the same one.
Yes, non-receptor mechanism, and I will ask you, non-receptor mechanism, does it mean there is a receptors when acid or antacids? Whoever asked me these questions, no binding, no receptors. It's acid or antacid, the alkaline and acid. But they're not up there. They need to read it. Antidote causing neuroplastic document in the presynaptic neuron. Yeah. What does it mean? Yeah. Yes, Bushra. Yeah. Yeah.
Regarding the shock, I was like witnessing some in the hospital. My mother had the shock, and they gave her corticosterone to reduce inflammation. Is that also
To reduce what?
the inflammation? She wasn't able to breathe.
Yes.
You said you give epinephrine,
Epinephrine.
but they give her a corticosterone.
Corticosteroid.
Is
They
that
give
also-
both. Steroids, it will help because I'm sure she has an allergic reaction.
Yeah.
Usually, if she has an allergic reaction, depending on how much she's bronchoconstricted.
It was like her voice was completely.
Sometimes they give IV or IM with steroids. It will help, but at the same time they need to give EpiPen. They did not give her epinephrine. No way. No
She
way.
gave her corticosterone.
That's it. No
But
way.
she had high blood pressure. That's I saw it. Like, I don't know.
So I doubt. To have bronchodilation, they give epinephrine, especially in, that's why you have the EpiPen. You know, the EpiPen in the emergency card. So this one, may the doctor repeat the carrier drug action of norepinephrine? No, I will not repeat it because it's not included in this. It's more, this class is about G proteins. So this, they will take it more. This is an example how the medication, they might affect the carriers. You will take it more about norepinephrine. If you block the norepinephrine carrier, it means no more norepinephrine entering inside, and you'll have more norepinephrine. This was an example only. Active, what does it mean, active? I don't know. EpiPen life, cyclical.
Answering your questions.
What's the difference between GQ and GIGS? Sarah,
No, doctor, they answered it later.
they answer. What's the
Someone wrote it over.
GQ? خلاص. They talk to each other.
Yeah.
Epinephrine bind to B1, not only B1. Epinephrine later on into Y, they are ahead of. By the way, the epinephrine, it acts on all receptors. You will take it later on with. I think Dr. Manal, she's going to give you the sympathetic mimetic. Nothing. Well, okay, thank you.
Yeah, doctor, they're answering the questions.
So they are answering themselves. Let me tell you, I don't know, you have a lot. Maybe I guess it wouldn't be to the effect will
Doctor,
take
can you
stuff.
go a bit up? There was a question. Can you please explain the histamine part again?
Histamine part, what did I say about it? Which part?
I think
Can you remember?
The
histamine and bronchodilation. Like if somebody has like a bees, I don't know if they are online or I'm talking to. Okay, who asked me this question? Ahmed, I will not talk until you say yes, I'm here. Artiza Ahmed? Yeah, Ahmed.
Yeah, doctor, he's
Are you here? Okay. Ahmed, if you're asking me about the histamine and the physiological antagonism, this is how different systems, they can compete on each other. Is this his questions? I think so.
Ahmed, can you repeat your question? You can unmute yourself.
Mute yourself and ask me, Ahmed. Can you higher your voice because I'm hearing you from the, I don't know where. Okay, but why you are in a hurry? Can you answer him? when you give adrenaline and when you give antihistamine, it's very simple. Histamine, let's say I have like مثلا mosquito bite now, very simple, red here, it's itching, I will take antihistamine. But if I have a mosquito bite and it causes for me bronchospasm, shall I go and take antihistamine? Or I should go to the hospital or ER, they will give me epinephrine? You tell me, Ahmed. So you tell me, if I have a small mosquito bite with just little itching, what shall I take? Antihistamine. And if I have a bronchospasm and about to have anaphylactic shock, especially if you have severe bronchospasm, what shall I take? The adrenaline. So usually that's why you have the EpiPen. Please, if you have any question is not clear, by the way, thank you for those questions, because if it's really small mosquito bite, you give antihistamine. If it causes anaphylactic shock, or if you have severe bleeding, or but why? And I give it to histamine, and because sometimes some bites they might cause bronchospasm. So you might give them antihistamine in the upcoming days, but at the beginning at the ER, you want to overcome the histamine, the huge histamine release. So you'll give them what? The adrenaline or epinephrine. Any other question important? Thank you, doctor, sincerely. Thank you, Osama. I hope I make your life easy. Thank you so much. Thank you so much, my dear.
Thank you so much.
See you after the exam. Before the, I hope you do great in the exam. Did she attend, or people that are not attending you are allowed? Did you attend?
Yes, yes.
أحلف بالله. Yeah, take care. Thank you so much, my dear. Best of luck with them. Please tell they can always email me.
Yes.
Some of them they're emailing me, or I'm sending it to the